Good afternoon, everyone. Thanks for coming. A shout out to people on the phone. I get to introduce June Simmons, so this is a real treat, June, for me to get to introduce you. So thank you for coming. June is the president and CEO of Partners in Care Foundation in California. During my time in Washington as U.S. Assistant Secretary on Aging, I met June. I'm trying to remember how many years ago, 7 or 8 probably at this point. Following the passage of the Affordable Care Act in 2010, my staff and I at the Administration for Community Living and other leaders in the field started to look at what the potential was on the heels of health reform and how would those changes likely impact the future of the aging services that we were funding through the Administration for Community Living. And we could see that there would be a time, that early after the ACA, where we could find some opportunities to innovate and better connect community services with healthcare payers of some sort. And we could see this early. So I started to incorporate it into my speeches, because I did speeches like everywhere. And after one speech, June came up to talk to me. That's how we met. You came up to, I think we were in Denver. And here I'm out there telling this vision of innovation, and June came up and she said, I'm already doing what you're talking about. And she had been doing it for years. So we continue to work as national leaders to kind of refine our vision. And from the beginning, reached out to June and incorporated her as an essential partner. I had her come to Washington to train my staff and I on what you were doing. As we have expanded kind of the group of people working on evidence-based programs and innovation, June was always there. She really is, if you were to put community-based organizations and innovation in a bell curve, she's in the #1 slot. She said her nose is short because she runs into things. That's because she's in the #1 slot. There's no one ahead of June and Partners in Care. Even Merrimack Valley in Lawrence, Massachusetts. It's clear out there, but I put them too. June is really in the lead. And I had the tremendous opportunity to go visit her at Partners in Care while I was Assistant Secretary. So it's full circle. Welcome to Kansas City. She founded Partners in Care Foundation in 1997. She'd previously worked with Visiting Nurses Association, which is an organization that kind of ended at that point, and sort of from it, Partners in Care Foundation emerged. June has been at the helm the whole time. And she's really been a pioneer in looking at developing and scaling evidence-based models, leading interventions, finding an effective way to implement interventions, specifically focused on sort of the combination of people with chronic conditions and functional limitations. She's really at the lead. There's not anybody that we could bring that would have navigated these issues more than June, and she's in a huge system out in California, so she's worked with so many different kinds of federal funders, but also state-level partners. June has served on a number of national committees, has multiple awards and recognitions. She was on the Institute of Medicine's Committee on Transforming End-of-Life Care, and I call that one out on her bio specifically because we don't talk about palliative care very much in this context, but I want you to know that it's essential and it was foundational to the work that June did, and she's still very much kind of in this vein of looking at meaningful end-of-life care. She's a founding member of a group called the Evidence-Based Leadership Council. Where's my St. Luke's group? Orvie, you have a lot of licenses through the Evidence-Based Leadership Council. It's funny because they came to see me and named themselves in the elevator on their way to see me. It's like they arrived in my office and said, we came up with a name in the elevator, and it stuck. She was on the National Advisory Council of the National Institute on Aging. Currently, June and I serve together on the board of the National Council on Aging. So she has become a friend. She's a dear colleague, and I'm so glad to have her here. It's one of the things I can do best for Kansas City is say, I know some great people, they will help us, and June is here to do just that. So welcome, June.
Wow, I better be good, huh? that's anyway, we just work day to day, right? We don't think that way. Kathy, that's very kind of you. We all have benefited from Kathy's incredible national leadership, and I know you're delighted to have her back here, and I'm thrilled to see you moving in this direction here. So I'm going to try to talk about a little bit reinforcing your vision and then giving examples to try to illustrate what a wonderfully exciting journey of discovery you're on. So my short nose is from running into brick walls, discovering what it takes to take two very different cultures and service sectors and bring them into some kind of a wonderfully positive win-win that really improves patient care, really improves population health, and really and draws on the strengths of healthcare payers, hospitals, physician groups, and of community-based organizations. Better together than apart. So I'm just going to blither on here a little, and so I'd be very happy to, you know, stop if you have something you would like to ask about, because the whole point is, you know, it's a short flight from LA, I found. I didn't know, coming to your beautiful place. But, you know, I'm here right now, and I want to be sure I'm successful in thinking together about the important work you're considering. So Partners in Care is a not-for-profit in Los Angeles, and kind of a think tank and proving ground. So we have mud on our boots. So we're like, have ideas, we discover evidence-based approaches that we hope are economically sustainable and true enhancements for people's lives, so that we could have this. You know, for most of you, we're a rounding error. We are a community-based organization, not so big. But our ambition, our tagline is changing the shape of healthcare. So there, because, you know, I come from a hospital background, a home health background, I have social work training, but I'm very interested in what happens to people and what happens to these systems in this time of transformation. And we're all drinking from the fire hose of change. Huh? It's like, oh, which change shall we try? So this, I think, is critically a foundational one that crosses age boundaries, but is most rooted in aging. So we need these high-impact, solid approaches of looking at how people really live. We have, you know, this phrase, which we've all discovered, it's actually not a new phrase, social determinants of health, social and behavioral determinants of health, which is about how people live and how it impacts their health. So looking in that zone, we're very interested in consumer empowerment, skills development, and modification of systems of payment and care. There you go. Other than that, not looking for any change at all. But a grand adventure. And we are part of a national movement that Kathy really was a very, very key leader in, and that led to what is now the Aging and Disability Business Institute of the National Association of Area Agencies and Aging. That is a resource center that is funded by the John A. Hartford Foundation, the SCAN Foundation, the Moore Foundation, the West Foundation. So it's a nice foundation collaborative to advance this idea of integration of health and social services and enhanced self-management. Sometimes that one gets left out, but that's what we were talking about as we got on the elevator to talk to you. It's always an honor, you know, to take the elevator up to see the Assistant Secretary of Aging. It elevates your heart rate. It's a big moment for your work. So we found this graphic, which we think describes it. It's actually not a simple task. We are leaping across a chasm between these two worlds, but I do want to note that some people have made it across. You'll see that there are some successful people, but this is a somewhat pioneering territory, which means it's open for imagination, creativity, but we're really trying to bring those two worlds together, and money's moving around, so it's a time when innovation will occur one way or another. Let's make it great. And so that's what this is all about. And here's why. And I don't know, how many of you have seen this? Yeah, it's making the rounds. All we did was we pulled out the behavioral patterns, because it sometimes gets lost, because, you know, this shocking notion looks at what is it that, oh, it lost its heading. Its headings is factors in premature death in the USA, kind of a happy little byline there. But it does show that these things are powerful. They're not incidental. It's too pale up there for some reason. So what happens then is that we're now starting to talk about this a lot, and we're looking at housing. If we just get people off the street and in safe and supported housing, supported is the critical term. A roof is good. It's a great start. It's not enough. Food. We're figuring out about how important food is and how much nutritional insecurity there is, along with financial insecurity. Transportation, gigantic. Now, maybe here, I don't know if it's as big an issue. Most places it is. In Los Angeles, it's practically a death sentence. You know, it's just, if you've heard about our traffic is not as bad as our fires, but it's pretty exciting. So we like to note that social circumstances like those are really important. Access to those resources, and 3 huts and a cot, a shelter, access to care, but the behavioral patterns are gigantic. They are the biggest piece on this chart in terms of driving population health outcomes. Now we spend, I don't know how many $1 trillion on health care in America, but we're shifting, aren't we, to outcomes, to health, to healthy populations. So we have this combination of partnerships that are critical for that, and how people live is a major determinant. And so when we invest in that, we reduce some of the avoidable and inappropriate uses of the health dollar. So in a way, this is a talk about moving the cheese through integrating, because we don't want healthcare to build everything. This is a buy-build discussion maybe, but we want a full integration of a critical specialty resource that's called community care and the fantastic resources of healthcare. And we want to see how the new ways of payment will fund all of that and yield better results and not increase and maybe lower costs. Lowering costs might be too much to ask, but I don't think so. We see some very dramatic work going on across America. So does that make sense as a notion that we have been waiting till people got in trouble often, spending huge amounts on that and sending them out thinking they knew what to do, and then they would get in trouble. They would bounce back and be worse for it. So we want to improve the results of our loving investments. And so, we talk some about poverty, but I just like always to say it's us. It's not them. It's actually all of us, because if you've ever had a relative that, let's say, goes in the hospital and comes out of the hospital, and try not to hold hospitals as bad. They're obviously essential and wonderful. I worked in one for 2 decades, so I get it. People go home and they have all those meds, and they have things that, they got in the hospital. Anyway, a lot of things go wrong. And so it's a wonderful place, the hospital, as it takes new leadership roles in addressing broader health strategies for the community, is like the physician group and even the health plan case manager in a position to identify, if we target correctly, with whom should we make alternative investments, different kinds of interventions in order to optimize the overall health outcome. If I would see CMS, I'd say total cost of care. We could talk about it in a lot of languages, all meaningful and critical. But in my mind, they cross fee-for-service, Medicare, commercial insurance, Medicaid, the FQHCs, everybody. These issues actually hit all of us and our families and our workforces and our colleagues. And the people who most need us and on whom we spend the most money anyway are the people with chronic conditions. So right now it's the opioid crisis, but bigger than that, pardon the pun, is obesity. Did you catch that? There was a little humor there. Bigger than that. obesity. You know, whether it's hypertension, what's chronic pain, what you could name it, diabetes, an epidemic, you know, just tremendous issues. So those people who already have something like that, that's a place to intervene and change the slope of the progression of those conditions at their own hand in partnership with their health and social services resources. People with disabling conditions for sure. I mean, that just is a complicator of life and physiology, and of course chronic behavioral health challenges. We'll see at the end if you think I have one. Just trying to get a little levity in there. So we can see, you know, across the nation this debate about Medicaid and who should have it and why and under what circumstances. But happily, Medicare is not in debate, and actually Medicaid is in kind of a exciting transformation. So, and it fell off the bottom there, I'm sorry, but it says Advantage, Medicare Advantage, expanding Medicare Advantage, and fee-for-service Medicare Part B billing codes. You know, CMS is like, had a transformational moment where they went from, we will only pay for strict medical interventions to they will look at health impacting and physical independence impacting resources, and it's quite an open question. So watching what happens with Medicare Advantage plans, whatever they do with that broad ability to change benefits and to even target them, so they don't have to give everybody the same thing, they can take people who need more and give more. These are, wow, you know, shocking moments of change before us, not yet defined, but happening. You know, supposedly happening 2019, but there wasn't enough time. So 2020, so this is a critical design year. So I think, you know, these are important opportunities, and the physician Part B. So now it's really the time for the change you're looking at, I think, to really think about seizing the moment, which you have been doing, and you know, if I'm cute enough, maybe I'll encourage you to stay that course and pursue that vision, because you know, you're all in the field you're in because you care about people's lives. You know, you want to alleviate suffering. You want to help optimize families and individuals and have them succeed in your community. And these are resources that will go straight to that. You know, we'd rather spend money on this and reduce the use of inpatient mental health, prisons, homeless shelters, you name it. So transforming Medicare is right before us, and it's a fantastic opening. And my observation is whatever Medicare does, it gives permission to the commercial health plans then. So it's sort of like an entry that can have a positive spreading effect. So here's what we're proposing then, that we take the gifts of our healthcare system and our social services, community care, aging network to strive for transformational change. One step at a time, because I mean, transformation, okay, get real. We have to do it in a way that works. So you have to weave it into your community so that it's a win-win for just about everybody. Because there is that challenge that if you say you're moving the cheese, we're moving somebody's cheese. And so there will be worries about whose cheese and if it's mine. So we really want win-win solutions that really do help invest in our community residents so that they have skills. And Kathy, I know, spread massive evidence-based programs that the Evidence-Based Leadership Council members developed that help equip people so they can make better personal choices. Help people. You've seen the literature now about loneliness is like creates a 7-year earlier death. It's definitive. And there's a lot of research out on it. So all these issues of family structure and environment and how to help people access the critical resources they need to be safe. Healthcare can identify people who need those things because social services is there and eager to help, not always fully resourced, but how do we figure out who needs stuff? Well, almost everybody goes to healthcare, and healthcare sees them and could have some simple tools for identifying those who should have a closer look to see if they need more and help lift those up and have solutions available from the experts for those kinds of issues. Now, maybe I should just see now, do you want to put me in one of those institutions, or is this making sense? Is this as an idea, a dream, a hope? Let's do it. Okay. And I just, healthcare, everybody knows healthcare. The hospital's been the center of the world. All of these resources are major, 18% of the gross national product, crucial. Social services agencies we know are there, but they're less well known. But they have a distinctively different role because they're extremely local, very personal, have a lower cost, staff and infrastructure and overhead, and they have very different skills. So I like to think of them as a specialty. We have many specialties, and it's a gap-filling specialty. We used to have a gap around late life care, and now we have hospice, and we're starting to have pretty widespread palliative care, home palliative care, which I think is critically important. You know how long those took and how evolutionary that was, because hospice started in the 70s in England and came as a volunteer program and became so PACE, same thing. So this is like that. It's addressing a chasm that people fall through and get in trouble in by redesigning the system to take into account what's missing, but doing it in a full partnership so that it really draws on the community care systems that exist. Are they perfect? Is medicine perfect? I say, we're all human beings. There's stars, probably you guys, and there's regulars and there's others that need to be improved. But it's a very important partnership. So I'm hopeful that healthcare will lead, co-lead, but not then suddenly think it should do this because there's local experts so that's what we're talking about, community-based organizations in full partnership with healthcare experts, using evidence-based programs and meeting high standards, just like everybody else. So we have to reach the members who need help, and boy, healthcare is really in a position to do that and not really structured to do it right now, but getting better at that. That's something that's really doable and crucial. We have to improve how people care for themselves. So all the evidence-based programs that we've been talking about that you do so well back there, they're about how people can learn to change their behavior, right? We all know you should eat right, you should exercise, you have to take your meds right, you should get to the doctor when you should go, timely, you should manage your stress. But getting yourself to do that, I always like to point out, I bought an elliptical and I kept walking by it and I didn't get any better. So it's all about how do you learn to change your behavior? It's all about self-efficacy. So there's a whole system out there already in place that can be drawn on, expanded, and partnered in. So I think, helping people get their support needs met in the community, especially for long-term care, all those kinds of things. These are very important. Working with caregivers, critical, elder abuse should be on the slide. We have to prevent, because, otherwise what happens is that people go other places that are inappropriate. They crowd them up. So you go to the emergency room and it's really hard to get in because it's all being used by a whole bunch of people who maybe should not have to be that sick or should be in an alternative setting. The hospitals are great, but they should only be used appropriately. Readmissions, no. Skilled nursing now, it's the next area that's under redesign. So all these long-term care. And then we really look for substantial return on this shift in our investments and very high member satisfaction, because a lot of people really are scared and frustrated and having difficulty navigating both systems. So we want the providers, the people who run these systems and give the care, to have better lives as well. You heard about provider burnout. It's a big issue, so we can do things better. So now, of course, I'm from La La Land, so I have to apologize from that. But, we're a little different than in our dynamics than you, which is why we did this before you, because we have a lot of managed care. I'm just guessing that you are not drowning in managed care. All our Medicaid is under managed care, and we have 40% of our Medicare is Medicare Advantage, and we have just tons of that. And so that lends itself, because managed care is really designed to try to make alternative investments in order to get better results, in order to cut costs. So it's perfect for what we're talking about. So that's probably why I started early on this. So just to say, I know I'm from a different environment, but your environment is now, the door has opened, the key has turned, and you have a shot. But then we're all facing some of these other issues, this massive consolidation. I don't know if it's affected you here. When CVS can buy a national health plan, you know, when Amazon and, you know, these are dramatic changes that are occurring in our nation around who owns and runs healthcare and what they're trying to do with it. There's a big move afoot. So we might as well be leaders. You know, if it's happening anyway, it's a moment of fluidity, I like to say. In an earthquake, we have a thing called liquefaction. So the earth is always solid, except in an earthquake, it's not. So when you have a good version of that, that's the moment to make change, because things get in place and they're hard to change. And then something shakes them up, and if you can get in there, you have a shot. So you know what a CBO is? CBO, community-based organization. So that's a not-for-profit, human services, social services, an area agency on aging, a senior center, Jewish Family Service. So the focus here is not to have healthcare not hire social workers, because of course that's what's happening now, and it's good. We're starting to look more holistically at people. But who's going to go to the home? And if we started with this, and the hospitals thought maybe they would, but at least in LA, they really didn't want to drive more than 3 miles from their hospital to make a home visit. It just really takes a whole day. So the idea of having a dispersed geographic system of care, of home experts, if you don't have a skilled need in the home, you need another skill in the home. Then having a partner in the community who can do that in close collaboration with you, linked up, very, very useful. And when they go there, how many of you have been in the home just, you know, looking not at your neighbors or your friends, but can you believe what you see? It's stunning what goes wrong for people. It's a really important technical term, the duh factor. Duh. I didn't think about that. Like somebody already has a blood pressure med, they get a new name, a new color, new shape. They take that home. They have the other one. They take them both. You know, things go wrong. We had a gentleman who was just so adherent. He wanted to manage his medications which the community experts have evidence-based programs called home meds that equip them to be the tech detective for the meds and see what's going on and get that information back to the medical center. So this guy was worried he'd forget, so he took everything in the morning, 3 blood pressure meds, sleeping pills, on and on. People have multiple meds. We did a study with UCLA. We follow their patients for their medical group. And we find the meds, we send it to their pharmacist who's embedded in primary care. What percentage of the high-risk post-hospital, high risk of readmission patients that we saw, what percent do you think had a reportable meds issue to the physicians? We were shocked. Yeah, about 2/3 would be typical. That's what we usually see. 99%. They just finished a dissertation, and this was a matched population. It had real science in it, and they had an average of 15 meds each. You know, each person has too many meds from too many sources. So you need somebody who can go to the home at least once in a while and understand what's going on, what the person is up against. So a community-based organization is going to bring you these kinds of service lines that you can put in play. You already heard health, self-management. We talked about that. We'll look at some results later. Short-term in-home services, typically post-hospital discharge care transitions, very powerful to do an immediate visit, see what's going to get someone in trouble, typically meds, don't know how to get to the doctor, food, bad food, no food, and then long-term supports and services. We won't talk as much about that today, but avoiding the nursing home, the Medicaid population. This is a growing movement. PACE populations help with that, but CBOs can do a lot to manage very complex individuals of various ages at home. So can you get a contract with a healthcare payer, with a doctor group, with a hospital, with a health plan? Here's the thing. You have to say, what is causing the pain? What is it costing? And who will save that money if they pay for it? You have to align, obviously. The hospital's not going to pay to empty itself unless it's in a risk contract where it's responsible, which can happen in LA. So this is important. But so we have a patchwork quilt of various kinds of payers, but it does just show that we have quite a few opportunities to work with reducing readmissions, sometimes paid for by hospitals. The Providence, St. Joseph's hospitals in LA County use us in that way, and UCLA's medical group. Home Meds Plus, Blue Shield of California uses us across the state for high-risk, complex individuals. The evidence-based programs, Blue Shield uses us for that as well, but lately Cedars-Sinai's medical group for geriatrics has brought us in. So the long-term services and supports. Now the new Medicare, we have just written a grant to implement some of those, and we're testing with one of the Providence hospitals, some of the Medicare Part B, the chronic care management, these new opportunities to identify and follow people over time at critical points and serve them. So a whole bunch of things. So here's the idea. You know how healthcare used to be a cottage industry, physicians all over in small little practices. Maybe you're too young to remember. In my lifetime, that's how it was. They all got organized into networks. Now when you get your healthcare, you have to pick a doc from your network, right? So we said, well, what's good for the doc is good for the gander. What's good for the doc is good for the community. So that's what we've created. So here's a California network of community organizations that has a range of service lines and can talk to these various kinds of healthcare partners and customize something that addresses a critical need in that organization and the population it serves. And you're all different, so, you know, everybody doesn't need the same thing. But does that make sense as an idea? It's a regional delivery system. It's a single contracting entity. Let's say it's a health plan. Let's say it's Blue Shield of California. You know, they can't go out and just deal with community organizations. What are they going to do? There'd be thousands of them. Are they going to go, and we have 58 counties and they have multiple senior centers. They just want Meals on Wheels to follow a discharge. It's a big deal. So these networks can organize around the service area of a given partner. So UCLA is a large regional referral medical center. So their patients come from all over that health plan. So you have to adjust your network's arrangement to your partner. And why would you want so many? So it's very important, I think. And then what the community brings, all these systems can hire their own social services people, but if you hire a social worker, I'm a social worker, so this is not a criticism. You've hired a social worker. Good job. But if you hire a network of care, you've got geographic dispersed coverage, multi-language. I don't know if language matters. In LA, we're like crazy from language. We have a fabulous diversity in our community. So we have like 100 languages. So we need something local that fits the culture and linguistic needs and the knowledge of resources in our communities. So we think it's very important to help healthcare, but also help the local agencies around, because otherwise, if healthcare just starts identifying and referring, they'll just create a big waiting list in those organizations, and those organizations will shrivel from a lack of resource. So you don't want to have an accidental side effect. You want to build a robust shared partnership. But the agencies have to do things, you know, they have to build all these systems, shared accreditation, information, technology. Whew, how about that IT stuff, huh? Sales. You ever known a CBO that had to do sales? I mean, this is exciting. New billing systems, the ability to do a contract. How do agencies contract with each other, and so there's been a lot of work at the national level to build prototypes, so there are sample materials to work from, customized to yourself, so you're not starting from scratch, so your nose won't be short like mine. We used to say we're building the plane while we're flying it, right? We had this idea, we're going out, we're gonna make a contract, we're gonna make sure we deliver. So this is it. We have to create this kind of what is needed to deliver the vision we have in mind. So for agencies, it's very important. JFS is here, they're great. They could be the lead, but could you be the region? Could you be the multi-region? Could you cover the whole MARC region? So, you know, if a healthcare entity wants one stop, the agencies have to build partnerships as well. And building out this contracting, if a bunch of agencies do it, duplicative expense. That's a big no-no in my mind. We need to really collaborate in this, and it takes a lot of time. I don't know if anybody's had to do a contract with a healthcare entity, first to get the agreement, then to get the contract. I think there are plots in educational institutions and any large organization that once everybody decides to have a contract, it goes, you know, there's like something that drives in front of the truck to block it and make it hard. So these all take a lot of time. And then you have to implement together. Because if that doesn't work, you can get a contract in no volume. So that's no good. So we have a network, and it has a management service organization or a central leading office that does all these business functions for the community organization. Make sense? So because the community has to meet health plan or hospital or whoever the health entity's requirements. Healthcare, one reason it's expensive is because it's great. One reason it's expensive is because it's so regulated. It's so complicated. So you need somebody who can make sure that the community agencies is meeting those standards, especially for security of information. PHI, very big deal. But also insurance standards go up, and staff credentialing is more formal, and typically the agency, most of these agencies are not licensed, so someone has to be accredited. The contracting entity has to be accredited. So we are NCQA accredited, and it wasn't on our wish list, but we're glad we did it. We're proud. So then there's quality assurance. You get the thing up, you got to run it. It better be great, right? You know how it is. I don't know if you know, but if you're working from the outside with healthcare, one mistake and, you know, you just can't be doing that. You got to really be high level. Anyway, that's what we want to do. So, and you have the accreditation standards to meet. So all of these functions are very important. And then all the business office functions. Again, you do not want duplication. You want an efficient system where just like doctors can doctor, nurses can nurse, and the MSO can do the hassle functions, these critically important administrative functions. So the community has the same structure in place. And then it's not all so easy to get every little community agency in your network. Do you need everybody? Does everybody even want in? And if they do want in, are they ready to perform? So you have all those kinds of romancing the stone functions of making sure you have coverage. It's not a small task to cover your state. You have a lot of rural. So what are your strategies for that? We have a lot of rural. We have a lot of land. It's on fire at the moment, but it's we have a lot of land. And so covering 58 counties, big deal. So you have to get it up, you have to get it good, and then you have to keep it good. So you can see, but it's kind of an exciting adventure, and you're on the cutting edge of change, and you're really touching lives for the better and helping save the crisis of funding healthcare in America for fee-for-service and for Medicaid. Very important, universal. So it's case, I'm talking mostly about case management, but you heard we also talk about self-management. The case management is most integrated, so we can look very quickly at that. The individual could be a social worker, but it doesn't, we are arguing, and so far successfully, does not need to be a licensed person. Healthcare has to have licensed people, but we are looking at an alternative specialty with a different purpose, a different form of engagement with people's lives. So we don't want to over-fancify it. We want to have a wide array of accessible and connectable individuals who have great personal engagement skills and strong capacity to follow an evidence-based intervention appropriately and be fully accountable and meet all those standards. And then we can structure a comprehensive psychosocial assessment in the home. People can gain those skills. Often we automatically use nurses for that. Well, nurses, of course, can do this, but we do not have enough nurses. And we do believe that this should be an interdisciplinary effort in America. So here are some of the things. I just mentioned the meds because the #1 driver of inappropriate hospitalization, ER use, and nursing home placement is medications. Anybody who has more than 6 is at risk. But some people have like 27. And a lot of them, somebody needs to figure out what they're doing. What do they have, what don't they have, and what are they doing with it? And getting into the hands of a medical professional, which we can do electronically with a strong evidence-based algorithm to sort out so we don't alert about all the things that we shouldn't. And there's a lot of de-prescribing going on now, but you can't de-prescribe. You can't pull out the bad meds until you know what they are. So you can do this with one home visit and a couple of phone calls, or with much more intensive up to and including 30, 60, 90-day with some of the behavioral health, 6 months, you can actually transform how people are doing in the community. So we want that alternative workforce I mentioned. Often we use typically a bachelor's degree, but it just depends on the community, the culture, and the talent that's available and the skill set that you need. I think we should keep an open mind. We can have licensed oversight, that's fine, but we need to have a relevant workforce to serve as the eyes and ears in the home, to get the information that healthcare really just doesn't know in the office, in the hospital, in an institutional setting. You have no idea what people are doing out there, and if you did. Now, when you get married like this, it is a little bit complicated.
This might scare people off.
I know. I thought about striking this slide. But I thought it would just show that when you first talk to each other and you try to do a workflow, which I don't know how many CBOs have learned to do workflows. I didn't know how before this. I still don't. My staff do, though. You have to figure out where people go in the system. So don't worry, it's simple and good. But you are trying to change workflows, which in some people's minds is a death sentence to an innovation, because it's, you know, very personal how they do their day. And we work in silos. So that's just important to keep in mind. So one of the problems we've had, which we're working now to solve, is you know, you get a contract and then the people at the line don't want to change their workflow and you can't get any volume. So it's critical to have volume. It's critical that the agencies respond immediately, appropriately, report back, that everybody gets trust going. That's just vital. And then we see with the network, well, then now you're running your peers. So how do your peer agencies feel about you? So if JFS is the lead, then, you know, are they going to go to their neighbor that they've always had and say, hey, where's your assessment? You didn't get out there on time. These assessments aren't written well enough. These have to be brief, complete, appropriate to the, so there's a lot of management issues that we have to consider, which you can see. They're sort of normal human behaviors actually happen in healthcare and they happen in social services. So those are just things the MSO has to manage. So you think of this as an evolution. You say, gosh, I hope you try this. I hope I'm not making it sound too complicated because it's fabulous. Because it makes lives better and it changes, people are very satisfied when they see somebody who's been having a lot of trouble and their health gets better and their energy gets better and their attitude gets better, and they love their healthcare system, and they love their social services system, and their cost drops. So, you know, this 5% of America spends 50% of the health dollar, so we don't just target them, but we can make a better use of that money and a better use of their lives. So and this just points that over time, we had to build this out, and that we hit various barriers along the way, which were exciting. And of course, once we mastered them, they were triumphs. So just remember, a barrier is a triumph in the future. This is just an example, like Blue Shield wanted the evidence-based self-management programs offered in any county in California where they had 12,000 or more members. So there are agencies. We've been building statewide capacity. You're doing that here too, I know, for others. So we could get people lined up and we could figure out where the members lived. We had to figure out how to map people, how to create a workshop within 7 drivable miles of somebody. And we had to create a call center. We had to develop a system and call as Blue Shield and engage people in this. But we went from a 2.7, now we're at an 8% engagement rate. We're having really learning. We're learning how to help people think that they could do a better job with their health. So then Blue Shield sends 70,000 member names, and we reach out and try to help them go into one of these programs and see what happened. And information technology, that, of course, that's not unique to this. That's just for everybody. So, you know, there's a couple of service lines to concentrate on, and we have some examples we'll show you that tell, does it work? So let's take UCLA. We had a federal demonstration out of the Affordable Care Act, the Community Care Transitions Program. We saw actually 32,000 patients for 11 hospitals across 3 years, and we dropped, for the high-risk fee-for-service Medicare patients, we dropped their readmit rate by 1/3 with a single in-home visit and a couple of phone calls, evidence-based, or an evidence-based telephonic program bridge out of Rush Medical. So it was good enough. UCLA liked it, and the medical group adopted it, and they decided they would contract for this, because before the government was paying for it. Now they're paying for it for their ACO, for their Medicare Advantage. So this is their data because they have all the claims outcomes. So they identify who's at risk of readmission. They give them to us. If we don't see them, they have a 27% readmission rate within 30 days. If we do see them, they have 10.6%, 2/3 reduction. So, and not a huge percentage of their population, though. So the power, the thing that thrilled us was that looking across their whole population for that large medical practice, for the population, there was a 3% reduction in readmission. So that's hard to achieve. So it shows that these evidence-based, Eric Coleman's work and Robin Golden's work at Rush, these interventions are really powerful. And when you add our home meds intervention to them, this is what you get. So these are exciting. We worked with a medical group, a very fancy managed care medical group, gets all the best results in the world, and we beat their readmit rate by 22%. We reduced ER visits in the first 30 days by 13% more than they did. And we found 77% had home safety issues, risk of falls, gigantic quality measure now, and 63% in this very good medical practice, big meds issues. So this is more of that same, this is the 32,000 people. The UCLA was part of that. And then those chronic disease self-management programs we talked about. We worked with a union that decided to train their shop stewards to give them the skills so they could work with their workers. These were hotel maids and food service workers, so they had a lot of chronic conditions. And they were insured by Kaiser. They were trying to drop their health premiums so they could get higher wages. They could get the savings for their workers. So you can see for yourself dramatic health changes from these people attending these self-management workshops. And their BMIs went down, their blood sugars, their blood pressures, their depressions, their pain. Whoa! And somebody said, hey, have I got a deal for you and I can fix all this stuff for you and your friends? Nice. So now's the time. Now is the time because we have just scraped through the surface of some of the proof of results that we've got, but they're all across the country. These systems are rolling out. I guess I didn't get my state map in here. I mean, my federal map. I had too many slides, as you can see. This is after I cut them down. I had a map of America that shows all the states that are building out statewide networks, these kinds of partnerships. And some of them are more robust, but you're on there. You're on there, you're gray. So it means you are in the works. You're in the learning collaborative. You are forming this. You have local leaders who are strong, capable. You're building out these partnerships. Everything's changing in how we pay for human services. There's suffering all around us that can be softened or stopped. So it's a really high mission opportunity. So I'm going to be waiting with bated breath to watch and see how you guys lead this and to learn from you. I even learned today. So That's it. Thank you very much.
How big was your scale and what were the first steps when you started? Because we're obviously big now when we're on that first rung. So what was the kind of scale and what did it cost to at least take that first step?
That's a great question. I think starting is the key. So we ended up having tried some of these things early on when managed Medicaid came to town, and we had some skills for these populations. But then we were funded by the John A. Hartford Foundation to build prototypes for this work. And the Administration on Community Living joined in, and others in the field of ASA and National Association of Area Agencies on Aging. So we had some money, but I think the thing you need is vision, will, and it won't take no for an answer in a nice way. You know, we say no just means it's a sign that we're going to have a much longer discussion than we were planning on. And we try to understand what is the no and to address it and go back, because this actually takes some money, but you can what's the word when you transition the use of, you can repurpose funding. In Los Angeles, under you, all across the country, some of the Older Americans Act money was converted to the evidence-based self-management programs. To get that money can only be used for those purposes. So some of that you have in place. The case management, your AAAs, your senior centers, your area agency on aging, their contract agencies, they have some resource there. So it's incremental. So if you build the partnership right, it's really the business development work that takes work. And some of that, as I say, there's free consultation now under the Hartford funding. There's sample materials, sample grants to foundations. There's a lot of tools to work with. So it shouldn't cost as much as it cost us, because we were able to win 3 of those care transitions programs and serve 32,000 people in 3 years under government funding. That was big enough that it kind of helped us learn and have a little bit of gain actually out of that to invest in this as well. But then some of it's just sweat equity.
To talk a little bit more about the time frames. I mean, when you start, how long does this realistically take to get started? And what I'd like to add to that, June, is a conversation you and I've had before about whether you ever needed proxy champions to vouch for you in this process, because we've often talked about you may need a doctor to talk to a doctor. So will you kind of cover both? I mean, the timeline, and then who has to carry the message to help this partnership work from the CBO perspective?
We're opportunistic, so we go where we can find an opportunity. So especially if you get some foundation funding, then you have an obligation to perform. It's much better. The care transitions work was like that. We had a duty, and the hospitals who took it with us, we wrote the grants, but we had a duty to build a system that would see 30% of their Medicare discharges in order to drop their readmission rate. So once we were funded, we had to start immediately. Well, you know, you do what you have to do. So it took a long time to get that money. But you've got foundations in the room, so I don't know what their investment capacity is, but they're friends if they can't, you know, they can always talk to other funders. We talked to someone yesterday at Hollywood Presbyterian Medical Center, and they have a new bundled payment program, and it starts October 1st, and they want to know how fast can we scale up. So we say, we'll be there. We'll figure it out. So I think it varies. Some things take a long time, but what we do is enter the neighborhood, and so we're one of the few community-based organizations that attends the AHIP, the American Health Insurance Plans Conference. We worked really hard. We got on their conference program last year. So I think it's important to attend meetings as a colleague representing this viewpoint. We were at the America's Physicians Groups. That's the managed care physician groups all across America. They're in 45 states now. They decided to adopt this model as a group purchasing organization where their members can come and get this kind of service with a discount. So if you have a managed care physician group, or maybe a physician group that isn't mainly managed care, but it's a member of that group, we'll work with you because we're the GPO, but we don't want to come to your neighborhood. We'll help you work with them. We have all the stuff it would take. You could kind of franchise that. So those things vary, but I think it's critically important to have a champion. You're a champion. You guys are champions. You'll find almost anywhere there's a physician, a nurse leader, a hospital administrator, a health plan executive that cares a lot about this because they get it. They're the ones that can lead the change. So your timeline goes whoosh, if there's an opportunity and they're standing there and they make it happen. And the Medicare Advantage is one of those. 2020, that's your timeline. Getting everything in place for that.
Goes back to what June had mentioned in her slides, the Community Care Transition Program, which was a CMS-funded demonstration program funded in different parts of the nation. And the question was, what after that was over, what percentage of the communities were viable and able to continue? Because there was different histories in different parts of the country about sustainability after that demonstration.
We have UCLA, which was 2 of the 11 hospitals were at UCLA, and they've been big players, and they never dropped it. We have Providence St. Joseph's, which is a major system in the country. We have them in LA County. It's not the same St. Joseph's, probably. I'm just keep shocking you. But okay. All right. Well, maybe they'll be friends. Maybe not. So they picked up, they had 1 hospital, and of all their hospitals, they had 6 hospitals. We worked with 1 of them and had great results in partnership with UCLA. The other 5 got penalties for high readmission rates. So they decided that they would sign on. And so they now have us as something we were longing to be, a regional delivery system for a major system like that. But the Glendale community had several hospitals. They all had leadership changes. One of them thought they could do it themselves. One got acquired by someone else. One had a new CEO, a new nurse leader. But the nurse leader we had at the end there was at our meeting yesterday, and she was the champion at this next hospital that we didn't serve with that program, but she's bringing us in for their bundled payment. So is it high? No. I don't think, nobody believes the numbers enough until they have a specific initiative where they decide this is going to really work for them. They have too much change going on. They just can't do every nice thing that floats by. So they have to be driven to something that's a meaningful leveraging investment that they can represent to their system as important and sustainable and contributory, has an ROI. So it was a start. CMS, buried it too. They didn't understand what it takes for a hospital to decide to partner with the CBO and identify and connect people. That's work. And it's disruptive and it's threatening. So it takes a lot. But now we have higher standards to say, well, if you want us, we need a certain level of penetration to get you an ROI. I'm not going to stand up for 2 people and do you no good. Too much trouble. And, you have to train your people, and we have to monitor, are they doing it or aren't they? So we're learning too. Some of it was probably we didn't know enough how to convert it.
Let me ask, do any of you have questions for June, or are there issues that we have identified here that we'd like to make sure we discuss while June is among us? Opportunities, challenges, anything in particular you want to make sure we pull out for the group. So let me turn it over to you all.
This is the best kind of panelist to be. You get to ask questions. So when I was listening to you and I was thinking about the conversations that the steering committee has had, and we've had with some of you one-on-one as well, a couple of issues you talked about really resonated with, and you can hear from some of the follow-up questions you've had here with some of both the concerns and the opportunity for the MSN in Kansas City. So, for example, you called this a critical design phase, I think, for Medicare Advantage or Medicare generally. So what do you, and you went through that slide, I think, because of the time pretty quickly. What specific services do you think maybe offer the most promise for Medicare, and particularly for the plans?
I think it depends on the plan and their population, but typically, you find that investments are easier if the metrics are fast, so you can see is it working or not. So reducing readmissions to the hospital for whoever pays for the hospitalization is a high quality improver for the hospital, for the medical group, and the health plan. And you can measure it. Did we or didn't we reduce readmissions in 30 days? And now under bundled payment, it's 30, 60, or 90. We've got some data coming looking at 1 year. A total cost of care. Can we reduce the use of the nursing home? Can we help people get home safely? Later, it'll be avoiding admissions. But I think those are things that help enhance access. Now, I'm not sure if I'm getting right at your question.
Are there any specific services you think
The services are the care transitions coaching and case management, 30, 60, 90, depending on their acuity level, are very valuable in stabilizing people who come out of hospitals or nursing homes. But they're also value on a targeted basis for people who are identified as complex. Maybe they're going to the ER quite a lot. Or maybe you just go through your meds and say, who has more than 10 meds? It'd really be a good investment, and is a high-cost case. You go, that's not working. Let's figure that out. So those are simple, and if you could send home health if they have a skilled need, but you send home health on Medicare and you have a global $3,000 investment already for an episode, whereas you have someone who's more affordable and can just service the detective and can also do some of the same things, look at false risks. So I think those are important to consider.
Marty, yeah.
So let me follow up on that. As partners been involved in coordinating non-emergent medical transportation or non-medical transportation? Have they been providing Meals on Wheels, any of those other more direct social interventions?
Sure. We actually started in this before this with the Medicaid waiver to keep people out of the nursing home who are on Medicaid. And so under the state waiver, we had contracts for transportation, home repair, bills paying, appliance replacement, expanded personal care, you name it, whatever are the factors.
That sounds like a California list. It's a little more expansive, I think. Yeah.
Is it?
Yeah,
oh.
but it feels like it is.
Well, in California, the nursing home costs $50,000 a year, and the waiver costs $4,000 a year, including home repair, fixing the hole in the roof, and accessing entitlements people have access to. So we're quite used to doing that on a case rate. We get $357 a month, and we have to find and supplement whatever people need to be safe there. And so I think I'm confident. We're just taking on 616 complex adults, not all old, on Medicaid who have much more extensive needs. I got a call today, actually, that one of our brand new ones called and wanted to talk to us, and he was in a wheelchair and he's on a ventilator. You say, okay, That's going to, well, not that we've never done that, but it's not typically who we care for. So I think it's very possible for the home and community-based expert to manage all those instrumental services and track the person, be the adopted daughter or son that they call, go to the home periodically, whatever it is, monthly, quarterly, and make sure they get to the doctor, make sure they don't go to the ER inappropriately, make sure you track their meds changes. So yeah, it's a great use of the CBO. That's long-term supports and services, and it's really fun and important.
Carrie had mentioned transportation in specific, June, because that has, in every meeting that we've had, come out immediately as a huge challenge here. And any other advice or wisdom?
Yeah, we have contracts for it. So you can get contracts. You can get a discounted rate with a cab company and insist that they let you train some drivers so that they're capable of caring for people who need more. You know, Lyft and Uber now have new arrangements, and there are other kinds of transportation resources. There's transportation funding through your senior centers already out of the Older Americans Act. That's really important, foundational system in the community. And so there's a wide array, but that's what the community guys are for. See, they're like, so I didn't even think, oh, transportation, that's hard. It is hard. But I mean, that's what we do. So I'm not as smart about it, but my team knows. They'll get someone there if they need an escort. You know, what do they have to have someone come in the house? Can they meet them at the door? Can they meet them at the curb? So there's a wide array of solutions, but you need a specialist who knows in their town, even which churches or synagogues have volunteers that drive people. I mean, there's hosts of solutions. They're not adequate. It is a big crisis in America, but I believe it's a perfect place to partner and solvable.
So you didn't focus on the national map, but I'm curious, do you think there is enough mature integrated networks across the country and resources at kind of the federal level and then agency level for senior leaders and these types of entities to guide us on the path? It all looks a little bit overwhelming, but I think there are models that can be replicated with relative ease. Would you agree with that?
There's a lot of experience. So, you know, I can give you this big picture. You got me out here, so I figure I'm supposed to sound good. But, you know, we could drill down to the basics and what makes it hard and what are the solutions there. And N4A has the Institute, and it's very effective. And ACL lends a lot of support. National Council on Aging lends a lot of support. But there's actual consultation out of the N4A grant that can be provided, and a lot of us are eager to help. No, there's not enough resource out there. That's why we're urging you to build it, because, you know, we've seen opportunities for transformation come and go. You know, they come every couple of years. And do we seize them and make them work? Or they can be ruined. So this is like that also. But this change in Medicare is the boldest opportunity I've seen, and I'm not too young, in my lifetime. And so, you know, you really shouldn't miss the gold ring as you go round on the merry-go-round here. It's a fabulous opportunity. It needs this community. You guys are strong. I mean, you know, you're the salt of the earth. You're top professionals. You have a great community, and you're a nice size. You could figure it out here. And we were dumb enough to try this in California. I mean, oh my gosh, you know, crazy. We're just a little crazy. But no, I think there's a lot of experience now, and a lot of success should be yours. But you do have to find a way to make it someone's job, and then you all have to join in and support them. And you have to be frank enough to really call each other out to produce. Because this is a moment. They're changing Medicare.
Yeah.
Medicare, traditional Medicare is CMS movement to paying for non-face-to-face services. So care management, remote patient monitoring, there's just new payment in the Medicare physician fee schedule, which enables a lot of these activities. We tend to think of Medicare Part B as services originating out of the physician offices, but in fact, it's opening up opportunities for these types of arrangements. On the Medicare Advantage side, it's the, whatever they call it, the balanced budget, bipartisan, but it's some B Act, right? Bipartisan Budget Act included a provision that now allows Medicare Advantage plans as part of their medical spend. So 85% of the premium dollars they receive, they can now use those dollars to pay for social interventions with particular individuals. So grandma needs a refrigerator to keep her drugs in that refrigerator. They can now pay for the refrigerator, and that's appropriate under their contracts with CMS. That starts in 2020. So that's when June is circling that date. It's because the plans now are going to be looking for those interventions to control the costs for those particular populations.
If only Medicare would pay for more, and that's what we're saying. It is that moment. It's an inching forward to some non deeply clinical supports that are essential for health.
We have to get it just right, because you know sometimes we have these opportunities come and they get rated. So this should be a brilliantly balanced, thoughtful targeting that really spends the right money at the right time on the right people and tracks the results. We can't let it get fee-for-service out of integrity. It's really a high moment for our country, I think, to seize.
Have we presented this to the American Hospital Association or the Missouri Hospital Association? I'll add Kansas there, just be regional.
We have not that I know of, presented to the National Association. We did meet with the Missouri Hospital Association with some of the hospital executives, only one meeting, myself and David Warm, and kind of floated the balloon. But we were early in our thinking, you know, a lot has changed since then. It was mixed. Yep.
And that's the metro area, so Kansas and Missouri side at the meeting, correct. So yeah, it's both sides of the state line. Hospitals are represented there. Yeah.
Yes, in the interest of time, we are going to end, and June has noted it's not a closed conversation. There's always more opportunity, which I completely agree with. So a couple of things I wanted to draw your attention to before we close this out. The Missouri Association of Area Agencies on Aging, some of you know this, was awarded an ACL grant, Administration for Community Living grant, to support the delivery of chronic disease self-management education through an integrated care network. And Mark is the lead agency under that grant. So that's bringing a lot of federal interest to the region for the next 3 years, $825,000 of support, and we'll be able to hire a project director to lead that effort and build out some infrastructure for program delivery. In addition, Missouri was awarded 2 more ACL grants under that funding line, which is completely unprecedented. There were 20 national awards, and we got 3 of those 20. So a lot of momentum and a lot of resources coming into the region that could help prop up some of this work. So we'll have more of that in the future. Our next meeting is scheduled for August 27th of the MSN Steering Committee. We are still continuing to gather additional data on the funding streams to present to the Steering Committee. If you recall, the grant funding for the business plan development of the MSN is expiring at the end of October. So we're still marching toward that deadline. We will have something for presentation and consideration by that time. And we're thinking the final product will be in a proposal type of format for the steering committee to consider, and we'll take work forward from there. If we need to schedule additional steering committee meetings, we'll get those on the calendar and proceed and kind of move forward from that point. But just so you all know, that initial funding is coming to its close, and now it's time to get our hands dirty and do the work. And with that, I don't think we have anything else. Thank you all for your time, for attending.